Hi, good evening. Am I audible, guys? Hello. Hi, good evening. Am I audible, guys? Yeah, I think. So let's start. I will share my screen. Today is the sixth class of our Basics of Cardiac Pharmacology course. I hope you all have attempted the exam. I hope you all attempted the exam, right, guys? If you did not attempt the exam, please attempt now. It is open, still open. So who has not cleared the exam, please do it now. And because if you are not attempting the exam, you will not get the certificate. So attending the exam is very, very important, right, guys? You have to do that. Otherwise, it will be very, very tough to get the certificates. Correct. So better you attempt the exam. And there are only 20 questions. People are telling that we have exams and we are not, able to give the exact exam. So guys, please do it because it is necessary and it is recommended for certificate because without exam, no certificate, right? Without exam, no certificate. So I did not close yet. So you can attempt anytime, right? Whenever you want. So let's start. So today we are going to talk about ARBs. Before going to ARBs, I should tell you guys that our course, which you can see on the screen, which you can see on the screen, today is the last date for this premium course, and this is the unique course in India, and we only conduct about medication complexities and errors. No one else. So if you want to learn medication complexities, register today. Register today. You have to register today. Otherwise, you will not get a chance to register again. We may increase the date, we may extend the date, but not sure yet. We are not sure yet, so you have to register today if you are thinking about medication complexities and medication errors. Right. So, yep, let's start. Actually, I was doing some connections and other things. We got late. Okay, so this course is going to start on 22nd November. Today is the last date, and this is the third batch of the course. Third batch, guys. Okay, and before that we had two batches, and those were very very successful. We have a lot of alumni with us of the course. Is it visible? Why it's not visible? Oh, okay, so I think now it will be visible. Yeah, yeah, and this course is starting on 22nd November, and every week we will have 2 to 3 classes. Okay, 2 to 3 classes every week, and then there'll be 3 exams, 2 assignments, and one final exam to assess you how much you have learned about the medication complexities and medication errors. You will get all the study material. You will get all the access to recorded classes. If you are not attending any, if you are missing in any case, okay, and these classes will be in the evening time only from 7 to 8. From 7 to 8. So I think it will not affect your daily schedules, right, guys? So let's talk about angiotensin receptor blockers, ARBs, right? ARBs are the angiotensin receptor blockers, right? Right. So as we have discussed the evidence, why we need to decrease the blood pressure. Why? Why we need to decrease the blood pressure? And why actually we are discussing hypertension or hypertensive drugs here? Because hypertensive drugs are having the major impact on cardiovascular diseases and cardiovascular outcomes. Major impact. You know, hypertension is the major risk, one of the primary risk factor for cardiovascular events. Correct. One of the primary risk factor for cardiovascular events. So we have to control hypertension. Otherwise, patients are there at the risk to get cardiovascular events like myocardial infarction, heart failure, arrhythmias, anything. There could be anything. Other problems also, cardiomyopathies and all. So, as we have studied in last class, if we are decreasing the blood pressure by 2 mmHg, we are decreasing the risk of ischemic heart disease by 7%, and the risk of stroke we are reducing by 10%, risk of stroke mortality. Correct. So we have to decrease the blood pressure definitely. Now, what is the hypertension algorithm? We are studying this hypertension algorithm for last 3 classes. I will not discuss it. I will just say ACE inhibitors and ARBs are the first line therapy for hypertension. ACE inhibitors and ARBs are the first line therapy for hypertension, along with other treatments, along with the other combination therapies. But ACE or ARB, right? ACE or ARB, not together. So ACE or ARBs are the first line therapy for hypertension, not only in hypertension, even in the heart failure cases. Even in the heart failure cases. So ARBs, what are ARBs now? The drugs which have the similar effect to ACE inhibitors, which have the similar effects to ACE inhibitors, but different mechanism of action. ARBs have the different mechanism of action, right? These are considerably newer class of antihypertensive drugs than diuretics or than ACE inhibitors. These are little newer, but of course these are almost 40 years old, 30, 35 years old drugs. ARBs were developed, guys, focus. ARBs were developed to overcome the several deficiencies of ACE inhibitors. ACE inhibitors had several problems. The patients were, facing cough, angioedema, and other problems. So they developed ARBs, angiotensin receptor blockers, to overcome the problems of ACE inhibitors. So ACE inhibitors were the first drug, then ARBs came. So these angiotensin second receptor blockers help relaxing your veins and arteries to lower your blood pressure. Relaxing your vein and arteries means what? Dilation. That means vasodilation. Angiotensin receptor blockers are basically vasodilators, right? So after vasodilation, what will happen? Your heart will pump the blood easier, right? It will increase the capacity of your heart to pump the blood. So definitely it will be helpful in your heart failure patients also. Correct. Angiotensin is a chemical in your body that narrows your blood vessels, narrows your blood vessel, and that increase the peripheral resistance, and then it increase your blood pressure. Correct. So angiotensin blocker will definitely reduce or control these effects. Correct. Angiotensin second receptor blockers block the action of angiotensin 2. Angiotensin 2. Okay. As a result, the medication allows your vein and arteries to widen. Widen means the dilate, and vasodilation is the effect, right? Vasodilation is the effect. So as we have discussed in last class also, RAS system, as you can just follow my cursor, from the kidney, renal perfusion, renin will release, renin will travel to liver, from the liver, you know, it will combine with angiotensinogen and make it angiotensin 1. Then angiotensin 1 will travel, angiotensin 1 will travel to your lungs, okay, to your lungs, and in lungs, angiotensin converting enzyme ACE enzyme will convert this angiotensin 1 to angiotensin 2. Okay, so this angiotensin 1 will be converted into angiotensin 2 in your lungs. Right now, angiotensin 2, this angiotensin 2 will travel to several parts of the body, several tissues. It will travel to the several body tissues and cells, like in kidney, in your pituitary gland, in your it will affect your aldosterone secretion, and it will go to the sympathetic nervous system, where it will affect your sympathetic activities. So this angiotensin 2, and how it bound and where it bind, angiotensin 2 will bind to two kind of receptors, one is angiotensin 1 AT1, and one is AT2, angiotensin 2 receptors. These are types of receptors. So it doesn't mean that your angiotensin 1, this angiotensin 1 will bind directly. No, this angiotensin will convert into angiotensin 2, the agent or the chemical. This is the chemical. And AT1 and AT2 are the receptors. Angiotensin 1 and angiotensin 2 are the receptors which are located at the various parts in the body, right, in the kidney, your vessels, blood vessels, and many places. So this angiotensin 2 will go and bind to those receptors and activate those receptors in different parts of the body, like in pituitary gland, in your blood vessels, in your kidney, and then it will activate the system, and it will increase your sodium water retention. It will increase your potassium reabsorption, and it will increase the sodium water retention, and it will increase the peripheral resistance in your peripheral arteries, and after that it will increase your blood pressure. Correct. So after this angiotensin, there are receptors where it will bind. So this angiotensin 2, again, this angiotensin 2 will be binding on receptor 1, AT1 and AT2. So where this ARBs works. Now if we take ACE inhibitors will be working in your lungs, and it will be inhibiting this ACE enzyme. So this when they will inhibiting this ACE enzyme, angiotensin 1 will not convert into angiotensin 2. But the problem here is, you have to understand here itself, in the lungs, when it is working, the angiotensin converting enzyme inhibitors, ACE inhibitors, when they are working in lungs, they will activate the bradykinin system, renin bradykinin system, so that bradykinin concentration will increase in your lungs. Okay, so this bradykinin concentration, when it will increase in your lungs, it will cause the congestion, it will cause the edema, right? It will cause the congestion and edema. So to avoid that condition, when bradykinins and renins will be in too much concentration in your lungs, it will affect it will affect your it will produce the cough, and it will affect your immune system as well. Correct. So to avoid that system, to avoid that procedure, to avoid those renin concentration production, or renin and bradykinin production, they worked on the drugs and they came up with ARBs. So ARBs will not work here in the lungs. Correct. Here ACE inhibitors work, but ARBs will work here when your angiotensin 2, when your angiotensin 2 will go to the different vessels, or different body parts, or different tissues or organs, and in that organs it will bind to 82 and 81 receptors. So now ARBs will come and it will block the 81 receptors, angiotensin 1 receptors at different sites. Correct? Angiotensin 2, this angiotensin 2, see, this angiotensin 2 will bind to angio 81 and 82 receptors, right? So now ARBs will come and block all the 81 receptors. 81 receptors, right? So see here. See here. 81 receptors and 82 receptors, what is the difference? And where we found these 81, 82 receptors and how they work, right? So 81 receptors are widely distributed in the blood vessels, kidney, adrenal gland, heart, liver, and brain. So focus: blood vessels, kidney, adrenal gland, and heart. These four are the main centers for blood pressure raise, right? When your blood pressure will constrict, then your when your blood vessels will constrict, your blood pressure will raise. Blood vessels will constrict means what? The peripheral resistance will increase and vasoconstriction will happen due to angiotensin 2, due to angiotensin 2 at angiotensin 1 receptor, 81 receptor. Correct? Angiotensin 2 is the product from angiotensin 1 conversion by ACE enzyme, right? Now, so angiotensin 2 will bind to AT1 receptor and it will cause vasoconstriction. It will reduce your cardiac contractility. It will initiate the aldosterone release. It will increase your glomerular filtration rate. It will increase your blood no sorry it will decrease your renal blood flow. It will decrease your it will initiate, or it will develop the cardiac and vascular hypertrophy. It will also develop the central osmoregulation. It will disbalance that central osmoregulation. These all functions are contributing in raising your blood pressure. Vasoconstriction will definitely raised by vasoconstriction is happened due to the peripheral resistance in your vessels. It has happened due to the peripheral artery, when the small arteries in your different tissues, the peripheral arteries will get the resistance. So those peripheral resistance arteries will create the blood pressure, will create resistance. And so that resistance will reflect in your major arteries, in your major arteries like aorta and all, which are connecting the aorta to our different tissues. So that vasoconstriction will take place there, right? When vasoconstriction will take place, of course your blood pressure will raise. Cardiac contractility, cardiac contractility, it affects the cardiac contractility. So that's why when we block 81, it will increase your cardiac contractility, and definitely it will improve your heart failure. Correct? It will increase your ejection fraction, or it will increase the pumping capacity of your heart. So it will improve in your heart failure symptoms. Then aldosterone release. Aldosterone is the major a key role. It plays a key role in sodium and water retention, right? It plays a key role in RAAS system. Correct? So it is also an important factor to increase your blood pressure. Then renal blood flow and glomerular filtration rate. These things are directly like we can say the direct contributors to your blood pressure raise. Then and 82 opposite 82 is actually distributed in the fetal tissues, expression in the adult brain. Some part of those will be available or will be occupied at the renal glands, ovaries, uterus, endothelium, myocardium. So it doesn't contribute much. It doesn't contribute 82 receptor doesn't contribute much in your blood pressure increase, right? It will not distribute much. Functions of these 82 receptors are possible role in growth and development, like anti-proliferation and inhibition of neointima and cell differentiation. So it is mostly in the kids when baby is born on before the delivery inside the mother's womb. It affects much there in the development process. But AT receptors are mainly working on the blood pressure raise, or on the heart functions, on the liver functions. Structure of the both structure of the of both of the receptors are same. These are seven transmembrane receptors, and these are coupling with the G protein, coupling with the G proteins. So AT1 receptor, where it is binding, what are the ligands of AT1 receptor? These are losartan, valsartan, hypersartan, and candisartan. I mean all sartans, all ARBs. And AT2 receptors are mainly working with PD. These are the these are the drug codes. These are the drug codes which are actually working in the fetus, right? Working in the fetus. So I hope you understand. AT1 receptor, ARBs are working only on AT1 receptors, and which are available in your blood vessels, kidney, adrenal gland, heart, liver, which are the most major function of AT1 receptors are vasoconstriction, cardiac contractility. I mean all opposite to the blood pressure raise, or all opposite to the hypertension. So these all function are contributory factor to develop the hypertension. Okay, so what are the indication of ARBs? Now we have discussed about the AT1, AT2 and how it works and where it works. Now, what are the indications of ARBs? First of all, hypertension. Of course, these are antihypertensive drugs. When patient does not tolerate ACE inhibitors. When patient does not tolerate ACE inhibitors, remember, means the patient is showing symptoms, or patient is showing some adverse events with with the ACE inhibitors. So we replace any ACE inhibitors with ARBs. It doesn't mean that we cannot use ARBs in starting, but we keep ARBs as a secondary option. But still, ARBs and ACE inhibitors are the drug of choice for hypertension, the first line therapy for hypertension. Okay, but ARBs are given mostly when ACE inhibitors are not tolerated well, and in other conditions also. I'll tell about other conditions. So ARBs, same like ACE inhibitors. ARBs do not interfere with cardiovascular reflexes. It These do not interfere with patients who have asthma, like beta blockers, because beta blockers are prohibited in asthmatic patients. ARBs do not cause lethargy, weakness, or sexual dysfunction. And ARBs, this is ARBs reduces the risk of mortality. This is ARBs. ARBs reduces uh, the risk of cardiovascular mortality, which is caused by hypertension, right? Which is caused by hypertension. So these are taken from the AHA and ACC hypertension guidelines, which are issued latest in I think last month only, in December, in October, from American Heart Association and American College of Cardiology. Then what is the second indication for ARBs? Heart failure. ACE inhibitors and ARBs are equivalent in symptomatic heart failure. What is symptomatic heart failure? Symptomatic heart failure means when the patient is having the symptoms of heart failure, like uh, what are the major symptoms of heart failure? Breathlessness, right? Breathlessness, dyspnea. Okay, dyspnea is breathlessness, right? Then orthopnea, then PND, right? What is PND? Paroxysmal nocturnal dyspnea. Means in the night while sleeping, patient will feel discomfort, and the patient will feel breathlessness. Okay, and dyspnea on rest, when the patient, even he is not working or she is not working, patient will still feel the breathlessness, right? And pedal edema. So these are the major symptoms of heart failure. In that case, ARBs and ACE inhibitors are equally working, correct? So but ARBs do not show the mortality rate reduction in compared to ACE inhibitors. These have little less. These are little less effective in case of mortality rate reduction in compared to ACE inhibitors. Okay, guys. So that's why ACE inhibitors are the primary choice of drug, and then ARBs are the secondary choice. If we have to choose between these two, otherwise ACE inhibitors and ARBs are having the equivalent efficacy in hypertension, even in heart failure. Correct? So as we have discussed, for ACE inhibitors, ARBs have the same effect in heart failure also. It decreases the arterial tone, reason blood flow to the heart, and it improves the ejection fraction. It improves the pumping capacity of the heart by decreasing afterload, and cardiac output increases. So I mean, when afterload decreases, then only cardiac output increases. So these ARBs also decrease your afterload to increase your cardiac output, to increase your ejection fraction, to increase your pumping capacity of the heart, right? So the venous dilation due to ARB, venous dilation, because these are vasodilators, right? So due to vasodilation, the pulmonary congestion and peripheral edema will decrease, correct? And then it dilates the vessel of the kidneys and increases the renal flow and helps to excrete the sodium and water. So it helps to decrease the edema and blood volume. And indirectly, it is decreasing the heart failure symptoms. Correct? Got it? Then it prevents the pathological changes in heart that results from the reducing the angiotensin 2 levels in the heart. Angiotensin 2 levels in the heart, when it decrease, the pathological changes will not happen. Pathological changes means the cardiomyopathy, or the size of epicardium or endocardium, right? So that changes will not happen when we are using ACE inhibitors or ARBs, correct? So these are also called as cardiac modifying drugs, or cardiac modifying drugs. Okay. Then what are the clinical evidences for these studies? Wall-Heft study, which was done between Valsartan and placebo. So Valsartan showed very impressive results in heart failure patients. It reduces the mortality. It reduces the heart failure symptoms. Elite and Elite 2 were very, very famous, randomized controlled trials in heart failure patients, which was done on losartan efficacy. Okay, so then losartan efficacy, was very great in heart failure patients than in compared to other placebo or drugs, placebo or other drugs where we have used that, right? So exactly, Val heft was for valsartan versus placebo, elite was for losartan, correct guys? So these we have taken from European Society of Cardiology heart failure management guidelines. And for the evidence, you can read, these papers are very good, we can say. These are the meta-analysis of the randomized controlled trials. So you will get all the randomized controlled trials are done on done on ARBs in heart failure. All ARBs in heart failure clinical trials you can find here. This is the title: Angiotensin receptor blockers in heart failure, meta-analysis of randomized controlled trials. So the conclusion of this trial, if you read conclusion of these trials and of this meta-analysis, if you read, this meta-analysis cannot confirm that ARBs are superior in reducing all-cause mortality or heart failure hospitalizations in the patients with symptomatic heart failure, particularly when compared with ACE inhibitors. When compared with ACE inhibitors, but the use of ARBs as monotherapy in absence of ACE inhibitors or as combination therapy with ACE inhibitors appears promising. Got it? Means ARBs in compared to ACE inhibitors are not perfect, are not great in compared to ACE inhibitors. But when we are using as a monotherapy or in combination with ACE inhibitors, then the results are promising, right? So you will get it from this randomized controlled trials meta-analysis. Then if you want to read the direct head-to-head comparison of these studies, recently published, I think in 2017, and last publication was from 2002. Yeah. So in this you can read the effect of angiotensin converting enzyme inhibitors, ACE inhibitors, and ARBs on cardiovascular events in patients with heart failure. This was again a meta-analysis of randomized control trials, and they showed the ARBs and ACE inhibitors have the efficacy, equivalent efficacy in heart failure patients. But as a monotherapy, ARBs are great as a monotherapy or in combination to combination with angiotensin in combination with the angiotensin converting enzyme inhibitors like ACE inhibitors. These are showing the great results. So the next indication is very interesting of type 2 diabetes mellitus. It decreases the morbidity in high risk patients, like it reduces the risk of diabetic nephropathy progression. It decreases the risk of diabetic nephropathy progression in diabetic patients. ARBs are the only antihypertensive agents showing evidence of reduction of renal failure in type 2 diabetes mellitus and nephropathy. So remember, ARBs are the most promising drugs with great effect on nephropathies. And nephropathies we are giving in our diabetes patients and nephropathy patients to reduce the renal failure risk. Got it? So these are recommended to lower the nephropathy in hypertension, diabetes, and proteinuria patients. In the patients who have hypertension, diabetes, and proteinuria, so we can recommend with ARBs, even over the MACE, even over the ACE inhibitors. Even over the ACE inhibitors, we can recommend ARBs. Where? In diabetic patients, because ARBs are renal protective in compared to ACE inhibitors. Got it? So these statements are given by American Diabetic Association guidelines. So these guidelines are very recent, published every year. Every year, American Diabetic Association (ADA) publishes the guidelines in the January month. On the 10th date of every January, they publish or they update their guidelines. So these statements were taken from the January 2020 ADA Diabetic Care Guidelines. Got it? So ARBs could be given as a first choice of the drug in the patients of hypertension with diabetes mellitus. Other indications are myocardial infarction. It decreases the chance of heart failure after an MI. It decreases the post-MI mortality rate. In nephropathy, again, it improves the outcomes. Improve the outcomes, right? So what are the mechanism of action? As I was telling, ARBs actually affect on 81 receptors. 81 receptors. 82 receptors. These, the binding to 82 receptor is just less than 10%. Less than 10%. But the binding to 81 receptor is almost 88 to 90%. Okay, so most of the effect is shown on 81 receptor. Correct. So as we can see here in the blue ink, we have written do not affect the bradykinin system. Right? ACE inhibitors releases the bradykinin or activates the bradykinin system, and it suddenly increase the bradykinins in your lungs. So what will happen in your plasma? What will happen if you have the high concentration of bradykinins? What happens? It will create what it will create? Cough. What it will create next? Angioedema. Right. So to avoid ACE inhibitor induced cough and angioedema, we have to shift to ARBs. ARBs will not affect your bradykinin system because these are not working in your lungs. These are working in the different locations in your body tissues, and these are binding to 81 receptors. Now, what are the 81 receptors? As I told, aldosterone release. 81 receptor is responsible for aldosterone release, sodium water retention, vasoconstriction, LOX1 expression, and myocardial and vascular fibrosis. So it will also induce the myocardial infarction. When we are giving ARBs, see, angiotensin receptor blockers, it will block here only. It will block the receptors. It will block all the 81 receptors, and then angiotensin 2. This angiotensin 2 will not bind to the receptor, and the receptor will not activate these things, these all steps, these all procedures, and your hypertension will not happen, will not be developed, right? So I hope you got the mechanism of action of ARBs. So let's read it. ARBs have the following actions, which are similar to ACE inhibitors. Like what? ARBs dilate arteries and veins and thereby reduce the arterial pressure and preload and afterload on the heart. It decreases, it reduces the arterial pressure, or ARBs reduce the arterial pressure and preload and afterload on the heart. It dilate the arteries and veins. So what it is? Vasodilators. Right? It these ARBs down regulate the sympathetic adrenergic activity by blocking the effect of angiotensin 2 on the sympathetic nerve release, right? When reuptake of norepinephrine will not happen, so what will happen? Due to the sympathetic nerve release, your major arteries or major veins will not dilate, will not will not show the effect of vasoconstriction, not dilate. Where vasoconstriction we have to reduce now. So by down regulating the sympathetic adrenergic activity, by down regulating sympathetic adrenergic activity, it will, you know inhibiting indirectly, or we can say directly, what? Vasoconstriction. So if the vasoconstriction is not happening, means what will happen? Blood pressure will not raise, your peripheral resistance will not raise, right? So the next, ARBs promote the renal excretion of sodium and water by blocking the effect of angiotensin 2 in kidney. As I was telling, angiotensin 2 is, binding to the AT1 receptor at different sites, like in liver, in vessels, in kidney, in your uh, aldosterone, or we can say the pituitary gland, right? In the pituitary glands and everywhere, like there are located almost in the every vital organ in your body, AT1 receptors. So these are promoting the renal excretion of sodium and water by blocking the effect of angiotensin 2 in the kidney, and by blocking the angiotensin 2 stimulation of aldosterone secretion. So aldosterone secretion is the, I was telling, this is playing a key role in sodium and water retention. Then ARBs inhibit cardiac and vascular remodeling associated with chronic hypertension, heart failure, and myocardial infarction. Right. So these are the drugs where we can use in hypertension, in heart failure, and in myocardial infarction, because these have the remodeling, uh, we can say the facility, or they have, these drugs are very much effective in the cardiac remodeling. So like if the myocardium shows some kind of changes in their shape, in their architecture, so these drugs like ACE inhibitors and ARBs can reconstruct those things, and it can, remodify those things, remodeling, right? So that process is called remodeling. So these can do the cardiac and vascular remodeling. What are the drugs? All the drugs with suffix sartan, sartan. If you look at any drug with sartan, so these all the drugs are ARBs, correct? So what are the drugs basically? If we look at the list through the Indian eyes, I will say first drug will be Telmisartan, then Olmesartan, then Losartan, maybe Valsartan, maybe Azilsartan, right? So first three drugs are not much used in India. This Candisartan, Aprosartan, and Irbesartan. These three drugs are not much used in India. We are not using in Indian populations because these drugs did not show any promising results in Asian and in Asian patients. All the Asian patients are majorly in South Indian patients did not show that effect what they are showing in European continent and in American continent. The patients, all the patients with hypertension in those regions, right? So these are not used here in Asian populations. In India, if you see, we are mostly using Telmisartan, Olmesartan, like sometimes Losartan or Valsartan also. And now, recently, Agilsartan has launched, I think, a year back. So we all are focusing on Agilsartan. Correct. So let's see at the dosing. Agilsartan is available as 40 and 80 mg tablet. So we can start with the small dose, or we can say the baby dose of Agilsartan, that is 20 mg orally daily, and maximum we can reach up to 80 mg. Correct. In case of Agilsartan. In case of candy sartan, there are very low doses for candy sartan, like 4 mg, 8 mg, 16 mg, and 32 mg. So in case of hypertension, we can give 16 mg once daily, maximum 32 mg. But in case of heart failure, we will just use half dose, like 4 to 8 mg by oral once in a day, and maximum daily dose we can titrate up to 32 mg of candy sartan. Okay, so aprosartan is very high dose. I mean, the dose effective dose is very high, like 400 mg and 600 mg tablets. In hypertension, initial dose we can start with 600 mg, and we can taper up to 900 mg. In case of irbesartan, in hypertension, we can start with 150 mg once orally, and maximum dose we can reach up to 300 mg orally. In case of diabetic nephropathy, irbesartan is very much effective in diabetic nephropathy. In compared to other sartans, in compared to other ARBs, irbesartan is most effective in diabetic nephropathy, but we have to use with very small dose, like 75 mg once daily orally, and then we can reach up to 300 mg. Now we come to the drugs which we are using in India the most. Losartan, available doses are 25, 50, and 10 mg tablets, right? So in case of hypertension, we can start with the we can start with 50 mg once daily, and then we can reach up to 100 mg once daily, losartan dose. For the stroke prevention, losartan can be used in stroke also. So in stroke prevention, in hypertensive patients with a history of left ventricular hypertrophy, initial dose again 50 mg, we can reach up to 100 mg. For the treatment of diabetic nephropathy, same dose 50 mg once daily, we can reach up to 100 mg. So losartan we can use in three indications: hypertension, stroke prevention in hypertensive patients, and treatment of proteinuria or diabetic nephropathy, guys. Okay. And olmesartan is available in the dose of 5 mg, 20 mg, and 40 mg tablets. So initial dose in hypertension is 20 mg once daily orally, and then maximum dose we can reach up to 40 mg. Okay, telmisartan is most widely used drug in India. Most widely used drug in India. Everywhere they use telmisartan. It is available in 20 mg, 40 mg, and 80 mg tablets. So telmisartan in hypertensive patients, we can start with 40 mg once daily, and we can reach up to 80 mg once daily. For the reduction of cardiovascular related mortality in the adult patients age of 55 years or older, who have the high risk high risk of cardiovascular events and who cannot tolerate the ACE inhibitors, we can give, right, we can give in that patients as a stroke prophylaxis or myocardial infarction prophylaxis, telmisartan, as I'm telling, most widely used in India. So because it has the good effect on cardiovascular protection. So this drug is known as cardioprotective drug, telmisartan, right? So initially we can start with the 40 mg, and we can reach up to 80 mg. or in case of the risk protection, in case of the cardiac risk protection, we can start with the 40 mg twice daily. Okay, then let's come to Valsartan. Valsartan is also now we are using in all the heart failure patients. So Valsartan is available in 40 mg, 80 mg, 160 mg, and 320 mg tablets. So in hypertension, we can give 80 to 160 mg once daily, but maximum dose of Valsartan could be 320 mg per day. And same for reducing the cardiovascular mortality in the stable patients with a history of left ventricular failure or heart failure following acute MI. In those cases, we can start with the low dose of 20 mg per day or 20 mg twice daily. I mean 40 mg per day, and we can reach up to 160 mg twice daily, means 320 mg, right? In case of heart failure, correct, guys? So we can start in heart failure. We can start with 20 or 40 mg by oral route, and maximum dose we can reach up to 160 mg twice daily or 320 mg per day. But we have to give twice daily. So ARBs known combinations, as you must have seen in India, or in abroad also, there are the combinations with ARBs, very famous combinations. First is like valsartan and amlodipine. So this is the very important combination. ARBs and CCBs are actually useful. We usually have seen like amlodipine 80, or sorry, amlodipine T, or Telma 80 or Telma AM. So that is telmisartan plus amlodipine, right? So valsartan and amlodipine is another combination. And irbesartan and hydrochlorothiazide in heart failure patients we can use. Losartan and hydrochlorothiazides in hypertension, and in heart failure we can use. Valsartan also we can use with hydrochlorothiazide. Valsartan we can use with beta blockers in heart failure patients, right? So there is a new combination now which is approved, that is valsartan and sacubitril. So the combination of valsartan and sacubitril is actually an appellation inhibitor, which is used only for heart failure patients, so this combination is basically for heart failure patients with the I think all type, we can say. We are using in all type of heart failure, like in heart failure with reduced ejection fraction, or heart failure with preserved ejection fraction. I mean the systolic heart failure and diastolic heart failure, we are using in all kind of patients. So the combination of valsartan and sacubitril is available and approved for reducing the risk of cardiovascular death. It decreases the hospitalization of heart failure in patients with chronic heart failure, and it in the patients who have the reduced ejection fraction. Reduced ejection fraction means less than 40%, less than 40%, because now heart failure is divided into three categories based on their ejection fraction. One is heart failure with reduced ejection fraction, where ejection fraction is less than 40, and then heart failure with mid-range ejection fraction, where heart failure ejection fraction is 41 to 49, and then heart failure with normal ejection fraction. So that ejection fraction is what? Ejection fraction is more than 50% there, right? Okay, so yeah. Now, what's the evidence? You can read this article if you want to read this article. Every drug, dosing, route of administration, everything is given in this article. This article is very nice, and this is published, very recently in August 2020. August 22nd, 2020, it was updated. So you can get it easily in Google, or in if you are going to NIH, NIH library online, NLM or PubMed, you will get this article. Angiotensin second receptor blocker by Robert D. Hill and Prabhakar Vaidya. So this article have everything about ARBs, I mean doses and administration, route of administration, and how we should take, and what are the indications. Everything you will get in this article if you want to read, right? What are the pharmacokinetics? If you look at the T half, half life, or doses and all bioavailability. Based on the bioavailability, if you look at the irbesartan has the 60 to 80% of bioavailability, but still we are not using in India. correct? And then we are not using in India because it does not have the promising results in Indian or South Indian, South Asian patients. So after that, if we come Telmisartan, Telmisartan is widely used because its bioavailability is 43%. 43%, and telmisartan has the highest half life, 24 hours, right? It has the t half unlimited we can say, what's t half, it has the great t half, it has the great t max, and the dose range is also, you know, very less, like 20 to 80 mg, and bioavailability is also good, like 43, and its elimination is by fecal, by feces. 98% is eliminating by the fecal elimination, correct? So that's why we tell telmisartan is the best for hypertension. After telmisartan, if we go valsartan, if you can look at the valsartan and olmesartan, these have the good bioavailabilities. Even the losartan around 30, I mean 26, 30, 33, they have the good bioavailability and good half life also, like 6 to 9 hours, or 13 hours, correct, which we can use in Indian patients or in our Asian black patients, right? So I think now we should move to next. Adverse effects of ARBs. Guys, adverse effect of ARBs. It is actually well tolerated drug, but still sometimes it can cause dizziness, headache, and the major side effect is hyperkalemia. It raises your potassium levels in your body, in your plasma, in your blood, potassium levels. So this is the major side effect of ARBs. If the patient is having more or potassium level at higher side, we should avoid ARBs, right? So the other infrequent ADRs are as we have first dose orthostatic hypotension in case of ACE inhibitors. Same, we have to monitor the patient for first dose orthostatic hypotension, because in some cases certainly patient can, in some cases patient will develop the sudden hypertension, the blood pressure will suddenly come down, right? So patient can even develop the rashes and diarrhea, dyspepsia. It can affect on the liver functions, liver enzymes could be raised in case of ARBs, muscle cramps, and insomnia. These are the infrequent areas, not exactly. Renal impairment is not exactly a side effect of ARBs, correct? These are infrequent ARDs. But hyperkalemia, we have to monitor the patient for hyperkalemia and hypotension, guys. Okay. So these are the adverse effect of ARBs. Now, drug interactions, very important, where we should consider ARBs and where we should not consider ARBs. So the concomitant use of ARBs with other RAS blockers like ACE inhibitors can cause increased incidence of hypotension, hyperkalemia, and changes in renal functions compared to monotherapy. So that's why we avoid always the ACE inhibitors and ARBs together. That's why we avoid ACE inhibitors and ARBs together. We should not give, right? The concomitant use of ARBs with NSAIDs, right, including COX-2 inhibitors, including aspirin, leads to attenuates of anti-hypertension effect, and it will increase the risk of worsening of renal function. So we should not use ARBs and NSAIDs together, right? Even including this aspirin, correct? And with diuretics, definitely it can cause severe hypotension due to the high fluid volume depletion, and it can cause severe hyperkalemia. Correct? Because the potassium level will be raised inside the body and sodium will be secreted. Correct? Cyclosporine also can cause severe hyperkalemia along with the ARBs, and potassium supplements also can cause kalemic effect, additive hyperkalemic effect. So we should avoid with these drugs and these supplements: potassium supplements, cyclosporine, diuretics, and NSAIDs, and ACE inhibitors majorly, right guys? What we should monitor: we should monitor for the blood pressure, baseline blood pressure, as ACE inhibitors and ARBs can develop the orthostatic hypertension. First dose orthostatic hypertension, we should look for the serum potassium because these are known to increase the potassium levels, guys. Okay, then we should follow the interval, follow the patients at different intervals to check the medication adherence, and to we should counsel the patients to reduce the risk of hypertension. We should counsel the patients to reduce the risk of early GFR decrease, like they can check the the calcium level, sorry, potassium levels and blood pressure, and they can check for any allergic reactions if they are developing after taking drugs. They can directly show the doctor, they can directly contact the doctor and check if it is a reaction of if it is a side effect or adverse effect of ARBs. we should avoid we should avoid ARBs in the patient who are pregnant, the ladies who are pregnant, or who are in the childbearing state, right? So we should affect, because it can affect the fetus. The side effects could be seen in the fetus. So now I have some questions for you guys. Ready for the questions? Ready for the questions now? So let us start the questions. ARBs increases the plasma potassium level. Yes, no, or it has the neutral effect on potassium levels. Yes, guys. Yes, no, or it has no effect on potassium levels. Yes. Okay. So of course the answer is yes, because ARBs are known for hyperkalemia. Okay, ARBs are known for hyperkalemia. Right. Okay. Then next question. Yeah. ARBs block renin receptor, angiotensin 1 receptor, angiotensin 2 receptor, angiotensin converting enzyme, or none of the above. What ARBs block? What ARBs block, guys? Okay. Okay, so I can see the YouTube reactions. No, not 3. Answer is 2. Number 2. Angiotensin 1 receptor. Remember, 81 receptor, not 82 receptor, Madhumita and Kezia. 81 receptor. For last 1 hour, I'm talking about 81 and 82. So angiotensin 2 will bind to angiotensin 1, I mean 81 and 82 receptors, and ARBs will bind to 81 receptor, and it will block the 81 receptor and decrease the blood pressure ultimately. So 81 receptor. Answer correct answer is number 2, angiotensin 1 receptor. Okay, then next question. 81 receptor, yes, number 2 is correct. Okay, so next question is, why it's not coming? Yeah, ARBs are recommended in gestational hypertension. True, false, or don't know? ARBs are recommended in gestational hypertension. True, false, or don't know? Angiotensin 1 receptor was the right answer. 81. True or false, or don't know? False. Of course, ARBs are not recommended in pregnant women. Okay, guys, ARBs are not recommended in pregnant women. Okay, then thanks for your patience and thanks for listening to the class. Okay, guys. So if you have any question, you can ask me now. If you have any questions, you can ask me now in YouTube, and here I am looking at the YouTube also. My iPad. Okay. Do you have any question, guys? You can ask me now. Any questions from here Zoom or from the YouTube? No questions. Okay. Okay. So thank you, guys. Thank you very much. Okay. Okay. One question is there. When to choose between losartan, telmisartan, and olmesartan? Okay. So telmisartan is probably we give in hypertension, and losartan we give in losartan and olmesartan, not olmesartan exactly. Losartan we choose most probably in our diabetic patients with hypertension. Losartan is a good drug for the hypertension and diabetic patient, hypertension in diabetes patients, right? Telmisartan only for the hypertension we can choose, and olmesartan and telmisartan for hypertension, but losartan we can use with the diabetic patients and heart failure patients. Losartan, right? Losartan we can go for heart failure patients also. In WellHealth trial, the mortality benefit of valsartan was found very low. No, but in pace in compared to placebo, the valsartan were valsartan was effective much. NC, yes, WellHealth study showed the low, you know, low rate of mortality, not the low benefits, but the benefits were comparatively high and significant when it was compared to placebo. So in clinical trials, they use two things. They use one comparator, they use one treatment drug. So either two drugs can be comparator. So like most probably, in the most of the recent trials, they use ACE inhibitors versus ARBs, like valsartan versus ramipril or valsartan versus enalapril. That's why they do the studies, right? But when they have compared, usually in the initial phases, when they conduct the third phase clinical trial, they use placebo, because placebo has no effect, right? Placebo has no effect, so to check the effect of the drug, they use placebo. So in the WellHealth trial, the valsartan group showed a significant mortality reduction than placebo, and not exactly mortality reduction, blood pressure improvement in heart failure patients, in heart failure patients. Yeah. Drug of choice for hypertension in pregnant women. Definitely not beta blockers. Definitely not these calcium channel blockers we can give at the first time. Calcium channel blockers, or then we can calcium channel blockers are actually preferable in pregnancy. Akshay is asking, what is neprolation inhibitor? What is the use of this drug in heart failure? Yes, neprylation is actually in your endocardium, or endothelium of the cardiac chambers or vessels. Endothelium, in the endothelium uh, there is one chemical which is called neprylation, and which has the neprylation receptors. So this is a most a prominent chemical, or we can say the entity which is developing the changes in your endocardium, developing the changes, like modifying the endocardial structure and causing the hypertrophy, causing the endocardial hypertrophy. So if you get the myocardium, myocarditis, or if you get the hypertrophies, cardiac hypertrophies, so there are the high chances of developing heart failure. So these neprillation inhibitor, this sacubitril, it inhibits the neprilysin receptors. So the neprilysin receptors will not, create more damage to the endocardium or a myocardium. And these are the disease modifying drugs in heart failure. Like they can even, improve the ejection fraction. Drug of choice for patients with hypertension and diabetes in pregnancy. Hypertension, diabetes in pregnancy, and calcium channel blockers are preferable, of course, but mm, we actually use calcium channel blockers, and in some cases we use ACE inhibitors also. Not exactly, but sometimes, right? Or the central affecting drugs, like uh, we use moxonidine, right? Moxonidine we can use in pregnant women. Okay, so Telmisartan is suggested by doctor, but its side effect is headache. If is there any replacement of this drug? Yes, you can replace Telmisartan by Olmesartan, or the this Losartan in the same category. Or if you want to switch, you can switch to ACE inhibitors if a patient is tolerating ACE inhibitors. Many batches of Valsartan was recalled from US market due to NMDA impurities, but not in India. That is not. I think I should not comment on this. Centrally acting drugs like clonidine and methyldopa can be used in pregnancy. Of course, centrally acting maxonidine, clonidine can be used. I was telling. Correct. First line treatment of hypertension is ACE inhibitors or ARBs. What are the precautions to be taken while administering COX inhibitors with ARBs in geriatric patients? Okay, in geriatric patients, when we are giving them these two drugs, we have to monitor the things first. We have to monitor them for their potassium levels. First thing is BP for hypotension and potassium levels for hyperkalemia. These two things we have to monitor when we are administering COX-2 inhibitors and ARBs in geriatric patients. So that I think you are clear with your answer, right? Okay. Any other questions? Okay, guys. So see ya. Thank you. Good night. Take care. Bye bye. COX-2 inhibitors, Sachin. COX-2 inhibitors are not recommended in hypertension. COX-2 are given for if they have the MI, right? What is the role of chocolate in hypertension? As doctor advised to have it. I will get back to you with the answer. I'm not sure. But chocolates are usually used in hypotension patients. If the patient is having hypotension, caffeine can increase the stimulation, sympathetic nervous stimulation. I think it could be a probable answer. I'm not sure. Okay. Yes, guys. Happy Diwali, everyone. Happy Diwali. Take care. We'll see you after Diwali on 17th. Chocolates reduces the hypertension, especially dark chocolates. Okay. Okay. But most probably maybe caffeine or the other caffeine contents in the chocolates can, suppress the sympathetic nervous system, sympathetic nerve, nervous system and sympathetic activities, and it can reduce the blood pressure. Maybe that could be a reason. I'm not sure. I'm not 100% sure about this. Can patient on calcium channel blocker take calcium supplements? No, not recommended. Patients on calcium channel blockers cannot take calcium supplements. Do ARBs have any interaction with antidepressants? Yes, of course. Antidepressants are, not exactly recommended with ARBs, because ARBs and ACE inhibitors, because these affect, these have the effect on sympathetic activities. Yeah, caffeine causes stimulation. Okay, Poonam Chauhan. That's what I said. I'm not sure. Chocolate ka idea, I don't know. I have to read this. Okay, because I never recommended any chocolate to any advice in hypotension or hypertension. So I have to read. Maybe caffeine ka idea is definitely there, but what is exactly they're doing? I don't know. Okay, so guys, I think no more questions. So thank you and good night. Happy Diwali. See you on 17th. Can we have question answer session saved? Yes, you can see this question answer session anytime in YouTube. And if you have any questions, you can update, you can, put down to the video. I will answer there later. Okay. Good night. Bye bye, guys. Take care.